Well, welcome, Dr. Terrezza, Dr. Bell. We're here, Eyecare Experts. We've got a topic today covering a few different things. We've had women's health specifically in the past, but today we're going to talk a little bit about men's health, migraines, and myasthenia gravis. Now, I think this is our first time with men's health and myasthenia, but we've done migraines before. I remember doing at least a few episodes on that. So if you want to go back, you can certainly go back and look at any of those prior podcasts. Link to our media site on TerrezzaOptical.com, and you can go to any topics if there's something that you see that interests you. But for today, we're going to go through all that, especially how it relates to optometry, relates to the clinic, what to look for, how we treat it, what we advise patients. So we want to kind of break that down. But for men's health in general, one of the things I found I'll start with is men experience certainly migraines. Usually they experience shorter and less frequent attacks than women. Usually, with migraines, the thing, a lot of people say, well, I've got a migraine, but sometimes it can implicate, clinical stuff, underlying health flags. There's other things that can go along with it.
I agree. The differential, I don't have it on the tip of my tongue now, but I believe there's at least 4 or 5 different types of migraines, and getting into that gets highly technical. So I think we'd be better off talking about symptoms and patients that come in with those type of symptoms and how we differentiate that from there. Okay?
Yeah.
So I've got a little
go into it.
Xerox. This is on the wall of the clinic because
is that Palafox office?
at my Palafox office, yeah, I have it on my phone. I just can't keep all this in my head as such. But the way I differentiate between retinal migraines and migraines with aura, that is either lights or flashing lights or colored lights that you see to the side, those have to be differentiated because they have 2 completely different etiologies. Monocular symptoms, 90% of those are retinal migraines, where migraines with aura only occur 25% of the time in both eyes. That's the first question I ask, is if you have it in one eye or both, okay? The other big one is there's a thing called a negative scotoma, which means that you lose an area of your vision. So if you lose an area of your vision during the headache, that happens in retinal migraines 84% of the time, and only 5% of the time in a migraine with aura. So that's a more generalized systemic stuff. If you lose an area of vision, that's happening in the eye, and that's an important way to determine that. The other thing is if it's a sudden onset, that is, you're doing something and all of a sudden, boom, you get hit with this headache. 80% of the time, that occurs in a retinal migraine as opposed to a migraine with aura, where it's only 21% of the time. The other big one that I use is if you're photophobic. What that means is you're very light sensitive. And 15% of the time, they'll be light sensitive. Only in 15% of the time, that will be a retinal migraine, whereas in 90% of the time, that'll be a migraine with aura. And on the scotomas, that was the negative one, is the retinal migraine. When you have a positive scotoma, that's with, 77% of the time, it's a migraine with aura. Now, a positive scotoma is different. That's where you see bright flashing areas and you can't see well with that, as opposed to missing areas, which is a negative scotoma. And that's how I differentiate. I use those same 4 all the time to try to tell, in addition to running fields, OCTs, pressures, and the rest of the diagnostic flow. But migraines ought to be treated with care, as they're symptomatic of possibly other issues occurring in the central nervous system.
No, that's great information there, breaking it down like that. So I guess most of us are familiar with migraines, and we talk about migraines, a headache, maybe it's certainly more severe, it's debilitating, maybe lasts longer. But as you were saying, the auroras, so you can have auroras before you have the headache in some cases. In some case, you just have the aurora, or what I would term an ocular migraine, without even having the actual pressure or headache. And you were breaking down kind of the percentages of what happens there, which is awesome. I know for us, sometimes patients will call up, especially if it's a patient that's just had a migraine for the first time or they're new to it, and they describe the symptoms on the phone. Hey, I'm seeing this kaleidoscope, I'm seeing these light flashes, I'm seeing this, I'm seeing that. And for us, we think it could be a migraine, but certainly if you Google it, and for us, retinal detachment, retinal tears have some symptoms as well. And so with anything, with any patient, we want to make sure it's not the more severe stuff. So a lot of times when we get these patients in, we want to dilate them, making sure the retina is intact. And also, even if everything is good there, we can tell, hey, does the patient have high blood pressure? Is there bleeding? Are there hemorrhages? Sometimes cholesterol, blood sugar issues. We can tell a lot by looking in the eye. And so it's always a good thing to do. But certainly we would much rather you come in and see us and for us to look at everything and say, hey, everything's good with the eye. Let's kind of work through this and figure out systemically what might be causing some of these headaches or migraines. But I'd hate for you not to come in. Like I had a patient a couple weeks ago that was went blurry in one eye, and then it took her about 3 or 4 months to come in, and she did have a retinal tear detachment. And so we always say, certainly the earlier we'll catch things, the better the outcome. So don't always assume that it's what you think it is. Even we've done this a long time. I don't assume looking at a photo that something is bacterial. I want to look at it. I want to test it. I want to check it and make sure before we're treating it that we're treating the right thing.
Oh, I couldn't agree more. The whole thing with primary care, it seems like you're dabbling in many things, and in some ways you are, but your role is to differentiate things and to rule things out and to do things in a logical manner. And then when you have isolated a problem, is it something that we can treat ourselves, or we have to send to specialties? I've been in the eye business a long time, and eye care has evolved. And back when I was at school at University of Alabama, there were only 2 subdivisions of the profession. There were optometrists and there were ophthalmologists. And the ophthalmologists pretty much did everything on the eye that required medicine and surgery. Well, the 2 have differentiated, and now you have certified optometrists, you have regular optometrists in certain retail locations that just prescribe glasses and contacts. Then you have medical optometrists like ourselves that really look at it as primary care medicine, where we differentiate what's wrong with you and treat that, or send it off to specialties. Ophthalmology likewise evolved, and there are now 7 or 8 specialties, including retina, including oculoplastics, including pediatric ophthalmology, including cataract surgeries, glaucoma fellowship-trained ophthalmologists. Did I cover them all?
I think you hit most of them. I can't think of one.
Yeah, there might be one. There's the oncologists, but there's only a few of those. There's one at Emory and one in Philadelphia and one in Miami. But they just treat cancers of the eye. So with that kind of differentiation, you don't want to tie up the time of a neuro-ophthalmologist who just does nerve problems related with the eye with primary care, whose job it is to differentiate it and see if it should be at a neuro-ophthalmologist's office. And that's basically the function that we serve.
Well, and to that point, that's the reason we have, certainly all the equipment that we have. That's the reason we certainly encourage and want to dilate patients when we see them annually, is to look for all of these things. Whether it's, we have OCTs, visual fields, we have ERGs, we have B scans, we have all these things to monitor, not only to determine certain things, but to monitor progressions. And certainly when it gets to the point where, hey, you need surgery, or hey, we need to do this or do that, we're going to get you to the appropriate party. We're going to get you to that cataract specialist, that pediatric ophthalmologist, retinal specialist. We're going to get you there and get you in the right hands to get it taken care of. But certainly with us, we can do a lot in-house. We manage, we treat a lot of these conditions. And certainly, I think in most of these cases, we can do it ourselves up until the point where it needs surgery, it needs a specialist, something like that. And then, like I said, we would refer you.
We can do that because we catch it earlier.
Yeah.
If it's late cases and it's stage 3, then that's going to need the specialists to take care of that. The whole point is to keep you from that being in that position.
Well, one of the things, just staying with migraines, ways to treat it. You know, there's various things. You hear patients say, hey, I go into a dark room, I lay on the floor, I put a wet towel on my head. I mean, you hear all kind of things as far as what people will do or try to do because migraines can be so severe and so debilitating. But for us, certainly the Avulux lenses have come on board. I know you know the history of that, and I think our patients would love to hear, especially the ones who are having these migraines and are having things that seem like there's nothing that can help them out. Avulux lenses is doing very, very well, I think.
I purposely tried these lenses on people, so there are a number of drugs on the market. It's too numerous to mention, but a lot of them are what they call beta blockers, and they reduce blood pressure and the vascular dilation of vessels that's thought to be associated, actually constriction, but let's not get into that. But when those drugs don't work, and I still see the patients, then the story on this was developed by the former head of the Cleveland Clinic, who was a gastroenterologist, and he had 2 little girls that he was very fond of, and he had enrolled them in pre-K, and they couldn't stand light sensitivity. They were very light sensitive. They couldn't stand lights. They were very sensitive to them. And as a function of that, it got so bad they couldn't go to school. By the time they were in kindergarten, they had to drop out. And being head of the Cleveland Clinic, he was able to hire in-house tutoring and homeschooling for them, but it got even worse. So then they couldn't keep the lights on in the house. And after that, he had to wear a construction hat with a little light on it when he wanted to get around his own house. And that went on for about 4 to 5 months, and he had enough. So he had taken them to all the big major medical centers in the country and gotten nowhere. And as a function of that, he hired a physicist with his own money and set up a lab. So light is made up of components, of wavelengths of light. And he tested the visible range of light. So there's visible, then it goes all the way to infrared, and then there's different types of light on the spectrum, okay, UV. Anyway, he blocked the light wavelength by wavelength. And over a process of 3 years, he found 3 wavelengths that when blocked, they stopped his daughter's headaches. He then proceeded to use this at the Cleveland Clinic. He got with neurologists, first started off anecdotal, and then proceeded to patent this. He then spent the next 10 years getting it approved by the FDA, which had happened 2 years ago. I met him in New York and was intrigued by his results. The lenses were expensive, so I had them on a, we'll try it on you. If it doesn't work, you get your money back. And that worked so well that I was getting about a 50% success rate with migraines that had been treated by injection, by medical drugs, and couldn't get rid of it. And I did. I was very proud of that. And the main, in my clientele, they couldn't afford the $380, which is the cost for the lenses. And so I did the trial basis, not for the $380, and I still have it at the office today, but for $25. So if it works, you then have the $25 put towards your bill of $380. By the way, they're very expensive and only made by certain labs. And that's all controlled by him, as it should be. He has no other investors in the company. But anyway, you pay the $25. If it doesn't work, you get your $25 back. Takes about 2 weeks to test the lens to see if it will have any effect. We've been using it for a while, and we're sticking at about a 50% success rate. But these were cases nobody wanted to mess with. So it's kind of like a surgeon. If you judge his success rate and you're into that, then you look at some surgeons and say, God, this is awful. But what you haven't taken into account is that the cases that he gets, no one else would touch. And therefore, getting any kind of success rate on those, you shouldn't judge them by that same number.
No, great point, great one. And again, that's the Avulux lenses to help with migraines. There's some newer options, I think, that are coming available, and certainly we will have everything available as soon as we can get it, because we want to offer it to patients. We certainly want to help them, and we're not cherry picking, like you said. We're trying to help anybody we can, whether it's mild, moderate, severe migraines. We want to do what we can. Excuse me. Switching gears a little bit, certainly the 3M today was Myasthenia Gravis. Certainly it's a chronic autoimmune neuromuscular disorder. And as far as things, we look for, I guess the top two things as far as diagnosis or things that you see is droopy eyelids, which is a ptosis. It can be one or both upper lids. Also diplopia, which is double vision. And I think just those two symptoms alone usually is found in 80–85% of individuals who have myasthenia gravis.
Yeah, there's a drug you can use in the clinic and put it in, and if it reverses the droopiness of the eyelid immediately, that's pretty much a mnemonic device for certifying the diagnosis.
So, droopy lid, unexplained, come in. Autoimmune, I think the good thing nowadays is everybody seems to be more aware of autoimmune conditions. I think, I hate to say it, but years ago, I think we just kind of wrote it off and, hey, it's no big deal. But I think nowadays people are realizing with any autoimmune how it affects you, it affects the body, and I think every autoimmune thing I can think of affects the eye to some degree.
Affects females in a way greater percentage than it does males, which is interesting, but still hasn't been figured out as to why that's the case.
So double vision, if you're, certainly you're seeing two of anything, whether it's side by side, vertically, diagonally. Certainly with stroke patients, they'll come in with complaint of double vision, but there's so many other things that can cause it. And it's tough. I mean, if you deal with these patients who are seeing double, it's hard to even, you'll see them sometimes come in with a patch over one eye, or they come in with their eye closed because it's just tough to walk around seeing double all day.
From an optometric perspective, the way you can help it sometimes, not all the time, is with a thing called a prism, which directs light from the original source to another source where it's closer to the other image, even though it's artificially produced. And the brain will synthesize those into one, but not all the time.
Well, good topics. I feel like sometimes we could go on forever, especially, just talking about our experience in the clinic with patients and family members that are asking questions. But I think we covered a lot today. Again, men's health, migraines, myasthenia gravis. Any other topics we haven't covered that you would like to hear? We'd love to hear from you. Certainly, thanks for supporting. Thanks for watching our podcast. I had a patient today that actually said he's been watching the podcast, and during the exam he dropped that on me. But it's always good to hear from patients and let them know that they're watching, or they're hearing us, they're seeing us. So we appreciate any feedback, whether it's good or bad. We don't care. We just want some feedback.
Well, you can hold the bad, but
yeah, or direct the bad towards you. No, I'm not
yeah,
going to say
absolutely.
that. But we appreciate it. Thank y'all, and stay tuned for future podcasts. We appreciate it.
We do.